jaundice. Jaundice is what? Yellow color discoloration due to increase in bilirubin. There are other compounds that can give rise to yellow color discoloration. They are not called jaundice. If you have hypercarotinemia, keratin is more or less yellowish. You can become yellowish. This is not called jaundice. Jaundice is yellow color discoloration of skin and mucous membrane due to increase in the concentration of bilirubin. So I'm not going into more detail. Now you can understand in early stage of liver failure there is going to be cholestasis, which means there is going to be block of the drainage of bile. Bile is containing also what? Bilirubin. So once you're blocking, they are going to backflow into blood. So you are increasing what? So predominantly it is going to be what type of hyperbilirubinemia? Conjugated type, or we call it direct type, because if you next year you are going to run this lab test where I will explain how to check this compound with special tests. So you don't need to add a special compound to change it to react with the reagent. So that's why it's called direct bilirubin, which is conjugated bilirubin. So usually once you are starting to develop liver disease, there's going to be inflammation, or there are going to be what? Injury, which is early injury. What is the most important earlier changes you find in the cell in case of cell injury? The most earliest finding. Cell injury. What is the most earliest finding? Huh? Most earliest sign of cell injury. Cell swelling. This is the earliest sign. Once cell is swelling, there is block of this bile flow. So the most earliest type of jaundice you find in early liver disease will be what type? We call it as what type of jaundice? Obstructive jaundice. But it is within the liver, it's not outside. But late stage, if you have severe liver failure, they are unable to take up also the indirect bilirubin and conjugate it. In this case you can develop indirect bilirubinemia. But technically, if they ask you a question, what type of jaundice you have in case of liver failure, it is mixed. Now you can understand, I told you two extremes. Earliest case is going to be block, that is called cholestasis. So this is technically direct bilirubin which is going to increase. We call it obstructive jaundice. If the liver is unable to take your unconjugated bilirubin at all, severe massive liver failure, in this case you will develop what? High amount of indirect or unconjugated bilirubin. But usually in case of liver diseases it is mixed. There is going to be block, they are unable to take considerable amount also. There is going to be mixed bilirubinemia or mixed hyperbilirubinemia. Is it clear? But earlier is what? Especially if you think about viral hepatitis, it's going to be what? Obstruction, or any type of early type of hepatitis or hepatic dysfunction, obstruction. After that it will be progressing. So if they ask you a question, you can write this is mixed hyperbilirubinemia. This is the typical presentation. Portal hypertension. So portal vein is draining into sinusoids, and they are collecting into central vein. At last it is draining into hepatic vein, and it is going into inferior vena cava. Now if you have what? Severe injury, so hepatocytes are destroyed, and there is going to be overactivation of the interstitial cells of, you can call it what? Etol. Yes? So they have two functions. They store also vitamin. They can also become fibroblastic like cells. So they start to be activated and they produce a lot of collagen. Now they are forming fibrosis. So what is cirrhosis? Irreversible fibrosis with regenerative nodule formation. So there is regeneration because hepatic cells are what type of cells? They are stable cells, but when you need, they can start to proliferate. Yes, they are not permanent cells. So when you need, they start to proliferate, they become a nodule. So this is called proliferation. Nodule formation, you have fibrosis, which is what? Irreversible. Once it is reversible, we don't call it cirrhosis. This is the definition. So once there is going to be regenerative nodules and fibrosis, what is going to happen? the portal vein which is draining into sinusoid, this is getting fibrous and compressed, so they won't be able to drain. So the blood which is coming from portal vein is not able to be drained, so the pressure develops in portal vein. This is called as portal hypertension. I am not going into classification. You can understand normally the pressure over here is about 3 to 5 millimeter Hg or 10 to 12 centimeter H2O. If you read medicine books, usually they use centimeter H2O. So 10 to 12. More than 12 centimeter H2O pressure in this portal vein is considered to be portal hypertension. Like we remember about systemic hypertension, yes? We are talking about 120 divided by 80, then we are having the borderline. Once it is above 140, below 90, it is called hypertension, systemic. Here we have the criteria, more than 12 centimeter H2O. This is called as portal hypertension. Now what is going to happen? The blood is going to flow back because portal vein is blocked, so there is going to be what? Bypass. If you remember about anatomy, I explained about 7 locations where you have natural or anatomic portocaval anastomosis. Now all of them will open. One of the locations is over here around your umbilicus. We have one tributary of portal vein. This is called paraumbilical vein, which is running through the ligamentum teres of liver. Now the pressure increases over there. It is going to backflow. So there will be backflow of the blood into the superficial venous plexus around your umbilicus. It will be looking like the head of Medusa. Where it is going to drain? Either to the superior vena cava through thoracoepigastric vein or inferior vena cava through superficial epigastric vein. So it will be looking like the spreading of snakes located around the head of Medusa. You watched that movie, yes? Clash of Titans. That is Medusa. So it is looking like that. That's why. So if they ask what is the mechanism of development of caput medusa, this is portal hypertension, backflow. Now another one presentation of portal hypertension is going to be what? Ascites, or in Indian English if you want to call, you can call it ascites. Yeah, so what is it? This is a type of edema. What is edema? Excess fluid accumulation in interstitium or cavities. This is a cavity. So technically accumulation of fluid in peritoneal space is called as ascites or ascites. So what are the mechanisms? There are multiple mechanisms you can see over here. One is portal hypertension. So portal hypertension will lead to increased hydrostatic pressure in portal vein. More hydrostatic pressure, decreased resorption, increased effective filtration pressure. We studied this, yes? More hydrostatic pressure, more filtration pressure. More oncotic pressure, more absorption pressure. We already studied. Decrease oncotic pressure, what will happen? Decrease net resorption. So what will increase as default? Filtration. So one mechanism is increased hydrostatic pressure because of the block, that is portal hypertension. Another one is going to be what? Hypo-oncotic edema. Same story over here too, because you have chronic liver disease, there is going to be decreased albumin. So because of that you are going to develop what? Hypo-oncotic edema. Except that there are also what? Once you have edema in different locations, what is happening? Technically, the effective circulatory volume is going to decrease. Kidney is absorbing water, kidney is absorbing sodium, it is coming into the venous side, but it is going to the third space. So you are developing what? Ascites, you are developing edema. So technically there is going to be low effective circulatory volume. This will keep activating renin-angiotensin-aldosterone system. But at this point it is becoming a vicious cycle. Why? Kidney is absorbing, it is not going into the blood vessel, it is staying outside. So it is running as a vicious cycle. So this is also third mechanism. There are 7 mechanisms, we know 3 more than enough. Portal hypertension, increased hydrostatic pressure. Another one thing is what? Hypo-oncotic edema together. The last one is what? Activation of or persistent activation of renin-angiotensin-aldosterone system, which means it keeps absorbing sodium and water, but it is not getting into the effective circulatory volume because it is going to the third space or like edema. There are others, no need. So this is same too. activation of renin-angiotensin aldosterone system plus hypooncotic